have seen a number of very nice images of the diseases, medical diseases of the retina, and how different is the uveitis from these conditions, and what information does OCT angio give us in these conditions. Now, because of, I think, the lack of time, I'll focus on very specific entities that we commonly encounter in our clinics and often we find challenging. And I will go over some cases of the white dot syndromes, which include punctate intraoculoropathy, mutes, AMPE, and the commonly seen ones that include multifocal choroiditis and serpiginous choroiditis. I will not be focusing on POHS and birdshot since it is not a very commonly encountered disease, especially in the Indian subcontinent. So let's directly go on to our first case. And I have a series of 5 cases here. And what we'll do is from each case, we'll try to get a learning lesson of how OCTA adds to our knowledge and helps us manage these patients. Now, this is a 24-year-old Asian Indian girl, and her complaint is very specific. She complains of multiple scotomas in the field of vision. She is a myopic girl, about -5 diopters. And what you can essentially see on the fundus is presence of these multiple yellowish lesions, which are involving the macula of both the eyes. And it's definitely much more prominent in the left eye. If you do an OCT scan, which is passing, let's focus first on the right eye. And here we're able to see that there is presence of a dome-shaped elevation, which is involving the outer retinal layers. And what you notice here is that there is a breach of the Bruch's membrane. The Bruch's membrane is not seen in the region where you would normally expect it to be there. If you compare the left eye, and these are scanned, this is a scan which is passing through the lesion, and what you're essentially seeing is an intact Bruch's layer which is there right under the lesion. Although the lesion appears morphologically the same, it's a dome-shaped elevation there. What is the significance of this? Probably the OCT won't be able to tell us, but let's go on further. So the diagnosis here is definitely punctate intraoculoropathy. It's a there is an RP elevation with sub-RP hyperreflective signals. And we're able to see the outer retinal disruption, which is very characteristic of PIC and a punched out lesion that you are appreciating over here. Now, this patient came to us in November 2017, and at that point, you can see that the vision was not a very significant complaint. She was actually seeing quite well, 6.9, 6.6, and the only complaint was scotoma. And in the right eye, you can see that this patient, over the course of more than 6 months, until June 2018, does not have much change on the OCT. The OCT appearance is practically the same. However, if you look at the OCT angio, which was done in November 2017, you find that there is a very small sort of a network-like picture here on the outer retinal slab. Now, this was the same that we observed in June 2018. And of course, like most of us would do, we don't have any fluid, we don't have really a guideline here, and we have not injected anti-VEGF in this patient. Now, moving further, you can see that from June 2018, just a couple of months later, in August, this patient comes with a hemorrhage. And you can see that this is a very important clinical sign here, where you have a hemorrhage which is associated with the lesion and you have a drop in the visual acuity. And of course, the first thing that you would like to rule out is presence of the underlying membrane. And as you see the serial OCT, although nothing much has changed between November 2017 to June 2018, you have fluid now in August and you have a significant drop in the vision. And if you look at the OCT angio, you find a very significant increase in the neovascular network. Now, this basically means that in conditions which are inflammatory, the behavior of neovascular membranes is not like your AMD eyes. These tend to progress really fast and they can cause significant visual damage by the time there is fluid in the retina. So the learning lesson number 1 is that I like to use OCTA in PIC to detect these inflammatory neovascular membranes. So if you talk about punctate choroidopathy, I do not use it to study the inflammatory lesion itself, but to reiterate, I use it to detect the inflammatory choroidal neovascularization. And a lot of these patients would harbor an underlying CNV. Moving on to my second case, this is a very typical presentation that we see in our country and in the Indian subcontinent. This is a young male who has bilateral diminution of vision. And I'm showing you the left eye first. And you can see a very characteristic serpiginous like choroiditis, which is involving the posterior pole. And the autofluorescence is showing you active lesions, which are hyperfluorescent. And so there is this stipple kind of hyperfluorescence. So most of these lesions appear active on the autofluorescence imaging. This is the right eye, and you can see that the active lesions in the right eye are actually involving the foveal center, which is a matter of concern. This is the combined fluorescein ICG of this patient, and you can see here, especially on the ICG, I'd like you to focus, you have these hypofluorescent lesions which are in the center, and these lesions are going to be hypo in the early phase, and they continue to remain hyper in the late phase. As you can see this blown up image here of the ICG, you can see that the lesion appears to be hypo in the center. And now this on your right is the OCT angio picture. And on the OCT angiography, you can clearly see this area of hyporeflectivity involving the choriocapillary slab. And you can actually delineate the involvement of the choriocapillaries much better on the OCT angio compared to the ICG. This is one very important advantage of the OCT angio. And as you can see here that this is a patient of serpiginous-like choroiditis wherein we know now that the primary pathology is involving the choriocapillaries and there is presence of inner ischemia of the choroid and you have defects on the OCTA flow deficits which exactly correspond to the ICGA. Now, if you look at this combined fluorescein and ICG during the healing process, once the lesions have healed at 3 months, on the ICG, you can actually see now that the lesions have nearly resolved. You do not have much of the hypofluorescence that you had at baseline, and so there is near complete resolution of the choriocapillaries inflammation. What does the OCT angio tell you? And the OCT angio very beautifully shows you the healing pattern of the choriocapillaries. You do have some disturbance of the choriocapillaries, and that can be made out very clearly in the follow-up image. So the learning lesson number 2 for us is that healing of lesions is accompanied by reduction in choriocapillaries flow deficit area in serpiginous-like choroiditis as well as serpiginous choroiditis of the autoimmune variety. Now, we have also seen in this paper is under review right now in retina that lesions which are less than 0.1 millimeter square tend to resolve with minimum flow voids. What do I mean by that? As you can see here, this patient has progressively shown you very good healing pattern on the OCT angio. But that's not always the case, especially if you have large lesions. For example, this patient here, as you can see, there is a large placoid lesion and on the combined fluorescein ICG, the image right on top of your screen, you're able to see an active lesion here on the ICG. The activity is determined by the presence of the hypofluorescence at the active edge. And you can see that the OCT angio exactly is going to show you that on the choriocapillary slab. So definitely what you're seeing, you're able to really co-localize very well on your OCT angio. Now coming to the patient at 3 months, and you can see on the ICG, the lesion has really healed well. You do not have the hypo edge on the ICG, and what you have is the disturbance of the choriocapillaries. There is a lot of choriocapillaries atrophy, and you're able to see medium to large size choroidal vasculature. If you do the OCT angio, again, you're able to see the same thing, a mishmash of medium to large underlying choroidal vessels, and you have a choriocapillaries atrophy, and this is different from your baseline image because here you do not have the area of flow deficit. So your lesions have healed, but they have healed with a lot of choriocapillaries atrophy. So moving on, I'm just going to erase all the ink, and this is our next case here. of a young male with no previous history, and the only complaint is spots in front of both the eyes. Here you can see on the ICG a large placoid lesion, and on the OCT you have disturbance of the photoreceptor layer. The placoid lesion is hypo to hypo on ICG, and the diagnosis I think is very clear, it's an MPE lesion. Similar to the serpiginous choroiditis, MPE lesions appear hyporeflective on the OCT angio. They have more confluent patterns, and again, we are able to confirm that this is a primary choriocapillaritis. So, the learning lesson number 3 is OCT angio shows you flow deficits in MPE, predominantly involving the choriocapillaries. Again, this is another patient, 51-year-old Caucasian woman. This is the patient that I had seen during my fellowship in the US. This patient has complaints of blurriness and spots in front of the eye, and you can see these hypospots which are present in the left eye. This is a patient of mutes where the lesions are hypo to hypo, but they could be iso to hypo on ICG. The OCT appearance is actually very characteristic. You have the sort of, like a blast kind of a thing happening at the photoreceptor layer, which is involving the ellipsoid and the interdigitation zone, but sparing the RPE and the underlying choriocapillaries. So the very important aspect of mutes is that you have an intact choriocapillaries layer. So even if you do an OCT angio in the choriocapillary slab, you will find nothing. There is no choriocapillaries ischemia in mutes. That is why there is a recent controversy where they're terming the mutes to be a primary photoreceptoritis. There is no alteration in the choriocapillaries on OCTA. And this is another patient with mutes, and I'm just showing this image to show you the importance of the blue peak autofluorescence and near infrared autofluorescence, which show you two diametrically opposite patterns in mutes. One is hyper and one is hypo. And this is one very useful investigation in patients with mutes. But remember, you will still find nothing on the OCTA. So the learning lesson number 4 is OCTA in mutes shows intact choriocapillaries. Finally, I would like to summarize by saying that in PIC, you do OCTA to look at inflammatory CNV. In multifocal choroiditis, serpiginous choroiditis, and serpiginous-like choroiditis, you would like to do OCTA to determine true choriocapillaries ischemia and to see follow-up of these patients. In MPE, you would find choriocapillaries deficit of confluent pattern. And in mutes, you will do OCTA, but you will find no choriocapillaries loss. And finally, to summarize, there have been number of studies using OCTA in retinal vasculitis. There is no such consensus right now to determine whether OCTA really is very useful in retinal vasculitis. Yes, it is useful in occlusive vasculitis to determine presence of macular ischemia and capillary non-perfusion, but this is one area of research which needs further focus, and we need to wait to find out if there are more studies coming up to help us in this field. With this, I would like to thank you and just hand over to the panel. Thank you very much.
So, thank you,